All right. Hello, everyone. It's great to be here today to talk about a really important issue in youth mental health. Thanks for the introduction. My background is in psychology and neuroscience. And so, yeah, I focus on trying to understand how we can leverage new technologies to improve our understanding of mental health, and how these problems emerge, and also how we can use them to. And so this does mean that I work closely with health professionals and youth with lived experience, as well as technology companies to design and test new solutions for youth mental health care. So I hope you have all had your afternoon coffee, because we're going to cover quite a bit of ground today. I do want to start by talking a bit about youth mental health generally and some of the specific trends and challenges in this area, including the role of social media and new digital technologies. Then I'm going to talk about or go through some of the opportunities that the digital world provides us in terms of both improvements to youth mental health care, as well as some of the challenges. And then finally, I'll touch on what the future will look like, which is maybe not as far down the road as you might think. So figures from large international studies generally show that about 1 in 4 people will experience a mental illness in their lifetime. And for many people, this will be short term, but for other people, it can be quite chronic and long term. And we know that youth is a period where most of these problems tend to emerge. So you can see here in this figure that we have the peak onset of most major disorders like depression or bipolar disorder or eating disorders have their peak onset during this period. And the long-term impact, unfortunately, can be quite severe. So many people can go on to experience many problems with their physical health or problems with functional outcomes into adulthood. But also the threat is very real in the short term. We know that suicide is the second leading cause of death among young people. And we know that adolescence is a period of profound change. So there are many reasons why things can go wrong during this period. So the graph you see here shows how the brain is a sensitive period of development. And we know that different brain regions are maturing at different rates. So emotional or threat regulation regions in the subcortical areas tend to develop earlier than some of the prefrontal cortex regions responsible for higher cognition functions like being able to weigh up different scenarios for decision making. And so this is happening at the same time as great and significant social and environmental change. So adolescents are starting to go to secondary school, they get their first job, their first romantic relationship. And what this all means is they start to spend more time with peers as opposed to their family, and which makes them more sensitive to peer influence and approval and rejection and these types of things. There's also increased autonomy as they start to get more responsibility, experiment with alcohol use, they leave school, they move out of home and gain more financial independence. And so the interaction of the changing brain and these novel social environments just mean that there can be great effects on development and the risk of these youth mental health problems emerging. Now, unfortunately, new data from a large Australian survey of over 20,000 people getting worse, especially among young people. So the authors of this study identified that there's a decline in mental health, which you can see in the figure on the right, where you can see that young adults, you can see a decline in mental health across all age groups. But in the other figure, you can see that greater declines are among those in the younger generation. So those who were born in the 1990s or the 1980s even. And so this shows that declines in mental health among young adults may be due to new forces or different dynamics that are at play. Now, many are quick to blame social media and technology. So the data they point to is quite compelling, and it resonates with a lot of our own intuitions about these technologies. We certainly know that young people today, they're certainly more online than any generation before. And as I have shown, the adolescent development means that young people are more sensitive and vulnerable to increased social connectivity or other reward-seeking attributes that are common to these technologies. And so when we see data like these two figures, where you can see a rise in the prevalence of depression or a rise in self-harm and suicide rates, which seems to correspond with the rise in social media. You can see on each of these graphs, there's a grayed out area corresponding roughly with 2010, which some people point to be this sort of period where there's a rise in social media, and a lot of these other bad outcomes tend to also increase. However, the relationship is a little more nuanced than these arguments suggest. So when we look at large international studies, which involve meta-analyses and reviews, the results tend to find mixed results. So some no associations or small associations, and really limited evidence of causality. What the evidence does seem to find, though, is that the way people use social media really matters. So if people are using social media in terms of in a passive way, infinite scrolling, or just using it to view other people's content, that tends to be linked with a range of mental health problems. But more frequent use in terms of active use to interact with people you might know in real life tends to be linked with lower levels of depression and anxiety. But the evidence also indicates there are individual factors that are really important for explaining the relationship between social media technology use and mental health outcomes. So people who have had a tendency for repetitive negative thinking, that can mediate the relationship between prior Facebook use and suicide-related outcomes. And females who actively use Facebook and subsequently perceive that that they received online support, they tended to experience better mood. And so while I think there are real risks for some people in terms of mental health problems online, there are also risks associated with oversimplifying social media as the cause, and especially jumping to actions like banning the use of social media. This type of action can have many unintended consequences. One of those could be driving young people to environments that are much more harmful online and unregulated, or failing to equip them with the kind of digital literacy skills that they need to navigate these complex environments. You know, we should be supporting their development in a way that helps them navigate these new environments, which are online. Our world is very online now. And so helping them navigate this should be part of their development, and we shouldn't be sheltering them from these kinds of environments. It also could lead to a missed opportunity for being able to engage young people in positive ways. So a survey from 2023 of over 2,000 young people between 16 and 25 showed that about 50% with mental health challenges were using social media as a kind of substitute for professional support. So they are looking for practical advice. They're looking for ways to cope, to learn about their conditions online. And so this means that we have a real opportunity to engage young people in much more meaningful ways and engage them in mental health care much sooner. And finally, the oversimplification risks neglecting some of the real causes, which are, unfortunately, they're complex and dynamic. The figure on the right here shows the results from a really nice study with thousands of young people, where they tried to take into account some of this complexity. So you can see many factors here: social media use, social factors, mental health symptoms, life dissatisfaction. And when they took into account all of these factors, social media use is one of the least influential factors associated with adolescent mental health and life satisfaction. So things like bullying or lack of family support or schoolwork dissatisfaction were much more important for life satisfaction and mental health in the long term. So smartphones and social media are likely just one element in a wider set of factors that are changing over time and involved in the emergence of mental health problems. And this view is consistent with how we have come to understand mental health and illness. So time and time again, people have jumped on the merry-go-round of reductionist causes, trying to identify a single gene or a single brain neurotransmitter or a single life experience like childhood trauma. And these efforts have continued to fail over time. So instead, the complex system view emphasizes that mental health and illness emerges from the interactions between multiple factors that are biological, they're psychological, behavioral, and social. And these can influence each other over time in really unpredictable ways. And this has an emergent nature to it. So we can see that mental health is not simply just adding up multiple risk factors, but instead it arises from complex relationships between these elements, like you see in this figure here. You can see things like mood and activity and sleep and social connection, which have all kinds of relationships and feedback loops, which may give rise to mental health and illness. And this is why simple causal views tend to limit our explanatory power when we're trying to understand and treat and provide effective interventions for individuals. In contrast, a more biopsychosocial, complex and dynamic systems view likely gives us the best chance to understand and even prevent the emergence of mental health problems in young people. And this is so important because we face many challenges in youth mental health care at the moment. On the one side here, you can see challenges related to the nature of mental health and the way it manifests. So mental health problems in youth tend to be heterogeneous, which means that there's major variation in the way two people present. So one person with depression could have completely different set of symptoms to another person. And similarly, there's also pluropotentiality, which just means that a certain set of symptoms or factors could lead to depression in some people, but not depression in another. It could lead to another disorder or not depression at all. And the figure you see here illustrates this in the difficulties that it presents us with in terms of diagnosis and treatment. And on the other side, you can see the challenges we face in regards to healthcare. So in terms of access, you can see that figure with the blue bars shows that just over 50% of people with depression in the past 12 months had contact with services. So what this means is that many people who need help never actually make it into health services at all. And this is due to various reasons like stigma or location or cost. And that's in high income countries. The problem is much worse in lower middle income countries. And then for those who actually decide to seek help, there are often long wait times, limited resources, and the inappropriate or inadequate care models to provide treatment. And you can see this in the other sort of three parts of that figure where you see adequate psychotherapy, adequate pharmacological therapy, and so forth. Those rates are much lower, meaning that people aren't really getting the care that they need, even when they do seek help. And so while technology certainly isn't the silver bullet here, their advancement is opening up really new opportunities and being able to help us transform the way we understand and treat mental health. The first is being able to enhance our understanding of mental health and being more precise in the ways that we manage it. So I'll show some examples of how smartphones and wearable devices and artificial intelligence can provide us with a richer picture of mental health and behaviors over time. And with these improvements means that we have the opportunity to provide much more personalized and timely interventions where we can enable much more prevention and more individualized approaches. And then finally, I'll show a little bit about how digital technologies can empower young people and are changing the ways we think of mental health care, the way it should be delivered, and breaking down those barriers and making support much more accessible and immediate for people. And this has implications for mental health care more generally, even outside of the youth area. So in terms of a deeper understanding, a very active and exciting area at the moment is an area called digital phenotyping. This involves the moment-to-moment quantification of a person's experiences and their behaviors. So the types of information that are typically available come in two forms. One is the kind of passive information that you get from sensors on someone's phone or devices they might be wearing, and this really doesn't require any input from the person. And the second type is active data. So this is where it requires someone to answer a question or a series of tasks actively on the device. And so what this means is that the way we use social media, the way we connect using our phones, our heart rate, our activity, all of these physiological and behavioral factors become part of a digital phenotype. And if you think about traditional mental health assessments and the way we diagnose problems, they've been limited to a specific time with a specific person at a specific location. And so this is a limited understanding of some of the complexities and dynamics that I've mentioned and that I've been talking about. But now with digital phenotyping and technologies, we can understand mental health and illness in the real life context that people live. So this is away from the clinic and in a way that's much more closer to people's lived experience of mental health. And that's really rich and helpful for us understanding what types of treatments might be suitable for people. So the figure here shows how we can go from information collected from sensors in the green area you see at the bottom. So things like location, app usage, higher level, can lead to then higher level behavioral features that you see in blue. And this kind of work has already demonstrated how digital phenotyping can provide new insights for how we measure and understand mental health. So, for example, fewer unique locations during the day or more time at home and irregular sleep are more distinctively associated with depression, for example. Whereas fewer text or calls in public or using your phone in the middle of the night have been associated with anxiety. And this work also shows that when you use artificial intelligence or machine learning to combine multiple features, so you take someone's mobility, their sociability, or their sleep features, you can improve prediction of certain mental health conditions by combining all these things together. And while those studies have focused on detection and prediction, this type of tracking can help us also understand more about causes over time, which are important for intervention. So one area that is this type of work is really exciting is understanding how our sleep and circadian rhythms is linked to mood. So circadian rhythms are a natural internal process that regulate the timing of pretty much most of human behavior and physiology. And it influences our biological functions, hormone levels, but also sleep and other body temperature, metabolism. All these things are controlled by circadian rhythms or affected by them. And so we can use activity monitors, mobile phones, and even light pins to give us distinct metrics that can help us understand a person's circadian rhythm or their circadian system and how it might be functioning because of these various inputs like activity and light and measuring things like sleep and energy. So for example, movement data from people's phones or their watches may be useful for detecting depression or bipolar disorder because these disorders are characterized by notable increases in the case of bipolar disorder or decreases in the case of depression in goal-directed behavior or energy and movement, which are likely to be captured by these types of devices. And when this information is combined with questions about mood and about energy across multiple times per day over many weeks, we can get useful insights into the dynamic nature of the relationship between many of these circadian factors and illness course and symptoms. So this work showed that mood and energy was largely a consequence of low activity. And so the implication being, if you could target people's activity, you could improve people's mood and subjective energy in the future. And so you can see those gold bars indicate the sort of significant relationship between activity at the previous time point and mood or energy at the next time point. And importantly, it wasn't mood at the previous time point predicting activity. So it's telling us something about what is likely to be a useful target for intervention here. And in this case, being physical activity to really have significant effects on energy and mood. And these improvements in measurement and understanding, means that we can provide much more personalized and timely interventions in a way that really wasn't possible before. So a type of approach here is called just-in-time adaptive interventions. And this is an emerging area where the dynamic needs of a person, as they change, so does the type of care that you might provide them, or you might deliver an intervention just at the point in time when they need it. So to continue the example from the previous slide, you know, if someone's activity and their sleep sensors were indicating that there might have been an irregular sleep pattern or there was really low activity during the day, this might be a signal that someone's mood or their energy may be at risk of decreasing in the future. And so this might be used as a way to prompt that person to take a look at their regular sleep cycle or recommend that they get some more movement throughout the day to help trying to prevent those types of things happening. Another one might be using geolocation or activity sensors or some other sociability indicators like someone, the frequency of calls and texts, combined with input about someone feeling lonely as a way of recommending certain interventions that might be useful for them in that moment. So I mentioned we'd be covering a lot of ground, so I just wanted to take a quick summary. So, mental disorders, we've talked about how mental disorders tend to emerge in youth, and it's a really critical period. And while trends do suggest that things are getting worse and new technologies may have a role for some people, the emergence of mental illness is complex and cannot be reduced down to single factors. And while youth mental health care faces many challenges in terms of understanding and access, the digital world is really providing us with new opportunities for measurement and for treatment. And so now I want to switch gears slightly and talk specifically about how youth mental health care is being transformed by digital technologies and how this relates back to everything we've talked about so far. So much of our team's work in this area has involved creating the future of mental health care, which is, in our view, is personalized and measurement-based care, which is supported by digital technologies. And in this work, it's about creating they don't replace face-to-face care, and they provide clinicians and young people with the information and real-time support that they need to provide better care. And the components of this are biopsychosocial assessment to really develop a more comprehensive understanding of a person's conditions and the range of factors that might be involved in their mental health. But we know that these assessments are limited, limited in their way of providing a view about what is really going on for this person, which is why routine and real-time monitoring is so important for this as well. And this is where the stuff I've been talking about digital phenotyping and other routine measures can really be used to understand more about an individual over time. And the final component involves shared decision-making. And so this is all about trying to integrate a person's preferences, their goals, their experiences, and making sure they're involved in the treatment decisions that are being made. And so over the past 7 or so years, we've been involved in the development of the InnerWell platform, which is a technology designed to help services provide exactly this type of care. And so in the screenshots you can see here, you can see there's multiple dimensions represented, and you can see trajectories over time, which try and show how what someone's illness trajectory is like and what this might mean for their mental health and their current mental state. And our preliminary work with health services in New South Wales shows that using this type of technology in services can reduce wait times for both psychological care and treatment planning by up to 60%, say. And it can also have an effect on people's experience of care. So you can see in that graph there on the right that people are likely to report that they don't feel like they waited too long for care. And part of the reason for these improvements is driven by our approach to responding to and addressing suicidality in these settings, which it's important to know that these aren't crisis settings. These are services that see young people that are at risk for these types of behaviors, but it's not a crisis service. And the figure here on the left, let me get my bearings right. Yeah, the left shows how we use technology to identify and respond to suicidality by giving people real-time pathways they can follow if in need, and by escalating these results to their clinical team. And so in this study, we had about 11% of young people who expressed high levels of current suicidal thoughts or current behaviors, and over 75% of these escalations were able to be resolved within 2 days. And that was usually with a safety plan or even being able to see someone for psychological care within that 2-day period. And as a reminder, this isn't a crisis service. So these people could have been waiting anywhere up from 2 weeks to 6 weeks before having seen someone. And so this approach ensures that people get the care they need sooner. And the technology proved useful for this. But beyond just triage and response, We can also use technology, and now specifically AI and machine learning, to understand more about these unique patterns that people might have. So for example, in this particular study, 74% of those included had some level of suicide ideation during their time in treatment. And the difficulty here for clinicians is that these patterns are very different for different people, and they're often quite difficult to predict, which really complicates individual decision-making and means that decisions tend to be reactive as opposed to being proactive. And this reflects kind of a general problem in mental health care, where we tend to collect a lot of data, but often after the fact or about the past, which means that very little of this information is being used to guide some type of personalized decision for a person in real time. So to address this, we built an artificial intelligence machine learning model to learn about the unique patterns of suicide ideation for each person. And so the red dots you see here appearing are the scores about a person's level of ideation over time, where higher means more severe suicide ideation reported into our online system. And the color lines you see, the squiggly lines, represent different estimates, some conservative and some more radical into the future. And where you see, and what you see as more dots are added is that the colored lines are becoming more and more narrow, which reflects the model's new predictions based on what it has learned about this person's unique pattern over time. And you can see when it restarts to the beginning that the predictions at the start are very wide. And when there's very little information about the person, they are highly uncertain. So I'll just wait until it restarts. It should be a second now. Yep, one moment. And then, so you'll see it go really wide, and then over time, so there you go, it's really wide. And as more information is being put in, the model is learning and dynamically updating what it knows about this person over time, which can tell us something really unique about a person's mental health and their progress and what they might need. And this is much more proactive and individualized than what has been possible in the past. And so when we do this for every individual in the study, we get very different patterns and therefore very different decisions that would be made for treatment. So if we focus on the panel A at the top, this person starts out with a moderate level of ideation, which tends to improve over time, over a period of weeks, and stays relatively stable. And so as a clinician, you might conclude, well, the current treatment approach seems to be working well, and so maybe a regular, typical follow-up period would be okay for this person. Now, contrast that to case D at the bottom, where you see a similar final level, of ideation at the final observation. So the dots are roughly the same as panel A and panel D, but what this translates in terms of a decision is very different due to the different pattern learned over time. And so this person has a much more volatile and variable trajectory. And so this translates to a decision that might be, well, let's review the intervention approach. Maybe we need to try something new, and maybe a more high frequency follow-up period is needed, maybe every few days, because this person is in a state that are of risk. And in the era of digital collection, we can use this type of AI tool to dynamically update when we request information from someone, using that HLT value, which just means, or just tells us how quickly is this model going to lose confidence in its prediction about this person. And I just want to emphasize here that the focus isn't really about prediction necessarily, but it's more so about what this learned pattern tells us about this individual and their particular mental health care, their mental health state, and what this means for their mental health care. And our work is showing how technologies are already transforming healthcare, and we have conducted qualitative interviews with almost 100 young people to understand some of their experiences of using technology to provide and to provide mental health care. And they tell us really interesting things, like they feel like the technologies have improved communication with their clinician. They feel more prepared by being able to go to sessions knowing what to say about their mental health since their last session. And that monitoring has made them feel more empowered to ask for what they might need. So they can see their progress against where they would like to be. And this empowers them to ask for what they want and say that they might not be happy with the kind of thing or the kind of outcomes that they're getting currently. And these attitudes capture elements of a paradigm shift that I think we're seeing in healthcare and beyond. So, you know, the digital world enables much greater opportunities to change the way that we provide access to quality interventions. So many young people who need mental health services, they don't often receive them due to the barriers I mentioned earlier about stigma, cost, and location. But technology connects us with rural and regional areas. So it connects people in those areas to mental health professionals and quality care. You know, the costs of online CBT tend to be approximately 15% of the cost of face-to-face CBT. The social media and online platforms are creating new avenues for us to facilitate access to care. So we know that by engaging people online can lead to future help-seeking behaviors. So it can be like a soft barrier into care. And so it creates new pathways for help-seeking. And of course, the 24/7 availability of support that comes from being able to use things online gives us an ability to reach people in the moments they need it. And we know that crisis lines tend to have their peak period in the middle of the night. So technology in this case can be really helpful. And so in my view, the future of mental health care is digital and it's integrated with traditional healthcare elements. And so many of the digital tools I've spoken about here today, like digital phenotyping, AI, online platforms, they should all be leveraged so that we can identify people sooner and engage them in quality care when they need it. And so as you see, as soon as we make, my kind of view is that as soon as we make contact with someone, as soon as someone makes contact with healthcare, whether it's online or digital, we should be doing our best to provide continuous, ongoing care that uses all of the information available so that care is dynamic and adapts to their changing needs over time and their changing goals. So this means that contact with traditional face-to-face care increases in times of need and when there's higher severity of illness, but may reduce in times of lower need. And so then online supports may become more useful. All the while maintaining sort of this aggregate tracking over time and monitoring so that we can be providing that kind of dynamic care. And this is taking youth mental health and really mental health care more broadly to a place it's never been before. Now, I'm under no illusions that the path is simple and that there aren't sort of challenges. So it really is our responsibility to ensure that we are developing digital health in a way that empowers rather than harms people. And not just digital health, sorry, but just these smart technologies and these social media. So we need to focus on building safer and smarter technologies, which requires this collaboration between industry, government, health service, and lived experience, and all these types of stakeholders being involved. And like just returning back to that issue of social media for a moment, you know, we know that young people want to be safe online. Not bans, but they want better tools. So this involves, you know, in improving platform algorithms, for example, to reduce the amount of harmful content that might be shown to people, while at the same time also increasing the amount of good quality, helpful educational content about mental health and other behaviors. And we really should be leveraging the advancements that we're seeing in these platforms, in artificial intelligence, to facilitate and support cognitive, social, and emotional well-being. You know, reverting back to a kind of technological primitive age it's not realistic, nor is it going to solve some of these larger forces driving the declines in mental health. So I said we'd cover a lot of ground, and we have. We've explored the real complex relationship between minds and machines. So the digital world, youth mental health, and it's clear that we face some significant challenges, social media just being one of those. However, these challenges should not be seen as reasons to retreat from technology. Instead, they present us with opportunities for innovation, for a deeper understanding, and for a creation of better solutions. You know, I've already shown how digital phenotyping and AI-powered analytics can help us understand complex patterns in mental health, which can lead to better diagnosis, prediction, and treatment selection. Talked a little bit about smartphones and social media as new vehicles for being able to provide real-time support and intervention for those who need it. And we haven't even touched on the possibilities of virtual reality for new treatments for things like anxiety and PTSD, which is another really exciting area, along with gaming, as another frontier of new treatments for mental health. And so I think there's often this dichotomy, you know, between pessimism and optimism in relation to new technologies. And so I really like this quote captured by David Deutsch, who's a physicist, who argues for the infinite potential of human creativity and innovation to solve problems, where he recounts how even while a pessimistic colleague was dismissing color television technology as useless and doomed, optimistic people were discovering new ways of achieving it and new uses for it, uses that he hadn't thought of and had ruled out. And so while I certainly lean towards the optimism, it's important that we go forward carefully and that we are mindful of the risks that we may be running into. But I think that we are in a really exciting time and a real transformation in the way we think about mental health and the way we deliver quality care that's in our reach and is in contact with us. And it's a way where we can improve not just mental health care, but the way we improve people's social, emotional, and cognitive development. So thank you for being with me, and thanks for listening.
We just have a few questions there, so can we read them out? Can the use of digital phenotyping be also useful to monitor mental health across other age groups, for example, older adults? If not, why?
Great question. It just so happens my background is in youth mental health, so I come at it from that perspective. But absolutely, the possibilities of digital health and almost everything I spoke about today really can be taken out of that youth context and expanded in other new ways. So in the sort of aging and development, the aging area, I know that sort of digital devices can be really useful for mobility and monitoring people's movement around houses. So, you know, smart technologies to look at how people are moving around the home or looking for problems there, and especially with falls and these types of things. So certainly digital phenotyping and these kinds of new technologies are not just in youth mental health, but applicable across the sort of age span for sure. It's just the use cases I sort of wanted to show were in youth.
So I've got one. Are you aware of the field lab at UNSW with Professor Jill Bennett's work?
Should be.
Yeah, it's. I was lucky enough to be at a talk on Tuesday night, and she's talking about how they work with Indigenous communities and use VR. And there's a 12-minute VR program called Connecting to Country. So yeah, I just wasn't sure if you were aware of that, but it ties into what you talked about. And yeah, it might be worth investigating or collaborating.
Yeah, we haven't done too much in VR, but we are having conversations at the moment because it is a really exciting area. I wanted to mention it at the end. I didn't have time to put a slide in, but virtual reality is it's a really exciting area. I mean, mental health is kind of interesting because we haven't really had many breakthroughs with the way we treat illness. You know, drugs haven't really changed, and psychological therapy is still quite the same as it has been in the past. And so VR is one of those areas where we have an opportunity to do treatment very differently. And, you know, especially in the areas of anxiety and phobias and that kind of area. VR and AR, so augmented reality, are really exciting avenues of developing new treatments. Things like agoraphobia, people staying at home, not leaving their houses, being able to use VR in a way to try and facilitate sort of that type of development and overcoming that is one exciting area for sure.
Because I come from a storytelling background. I'm curious, in that data, the stats that you were showing, was there any data collected in regards to the words people were using about themselves? And then in the process of change, was that wording of self changing over the time? Is there any way of finding out whether that's been collected or?
You're talking about the figure that was the dynamic changing.
Yeah, because there's lots of physical and chemical.
Yeah.
But what about the actual words they're saying to themselves?
Yeah, so that particular study was a kind of self-reported questionnaire. So we didn't actually collect sort of, people's words, but I mean, I'm sure everyone's aware of, the large language model sort of boom of the last few years. So, evaluating and analyzing people's text and understanding how they frame things and the kinds of words they use, that I've seen some studies already where that kind of thing is being useful for understanding depression and other kinds of behaviors. So another really sort of useful space. And I think it's really useful to, we often do many questionnaires or, like I've talked about, us set senses, but being able to hear or understand how people tell their own story about their own mental health and their own journey, I think can be really powerful as an adjunct to all of these other things that I've mentioned.
So in terms of the VR, I do agree that sounds like a really great opportunity. I've heard of startups that have been funded for PTSD to use VR towards veterans. But that's not my question. My question is,
I was hoping not, because I didn't speak about VR very much. No, I'm kidding.
My question is, you mentioned the sleep devices, the watches people are using to measure their sleep. Are all sleep devices created equal?
The answer is no. So we do a range of studies. We have some with kind of much more sophisticated sort of technology and actigraphy watches where they're not very appealing to wear and they look kind of ugly and people don't like them, but they do have sort of higher sort of quality of assessment or capturing. But so we do those types of studies. But I've seen some recent research which shows that the difference between sort of those devices and the sort of more popularly available devices is decreasing. So the gap is closing, sorry. But the other important factor here is, I showed a lot of things about change over time. And there was a reason for that is because, we often do one measurement and think that that's going to have good predictive value for the future. But, it's this repeat measure over time where you try and understand someone's mental state and or a particular set of variables and how they're changing. And importantly, how for an individual, how their own sort of mobility or mood or sleep has shifted. So we become our own baseline. So rather than, in mental health, we do lots of group studies. We get a group of people and we compare their sleep to another group and we try and, but those haven't really translated to individual sort of treatments or being useful for decision-making about what a particular individual needs. And this is where technology is giving us this opportunity to understand more about an individual. So provided the device has a degree of at least some sort of validity and reliability, after that, it's about, well, what can we learn about that person over time using that particular device, for example?
Thanks. I have a follow-up question.
Sure.
It's based on gender of the devices. So I'm finding that I can't wear the device anymore because it basically shows that I am declining in health overnight, or my health is rarely getting better, even though I've had 8 hours of sleep and I feel fantastic. Whereas my partner, who is male, is getting amazing results. And I'm wondering if that's because of the gender disparity in the data that's been collected for these watches in the first place?
Yeah, so if you're talking about, yeah, some of these, more widely available, devices and apps where there is some normative data set and then your data is being compared, there can be some biases in these data sets. I don't know the ins and outs too much of some of what those sort of biases might be, but it certainly is possible that something might not be as relevant to you and maybe have some gender sort of differences in there. So yeah, that's entirely possible, but yeah, I don't know. You might have to just, and you're actually touching on a different issue as well, which is, understanding more about, there can be too much feedback sometimes. And I think there are people doing research to understand, okay, yeah, well, feedback is good, monitoring is good, but there may be a point where too much sort of health consciousness and tracking of behaviors can also have negative impacts. So like most things, there's kind of a balance there that's needed.
Thank you.
Have you tried swapping watches?
That's also an option.
Yeah, just for one night.
So we have a comment here. It says, "Thank you for a great talk, Frank. The right treatment at the right time is an important focus moving forward in a rapidly changing world." And a question, as a high school teacher, what would you promote as best practice to encourage my students' self-awareness? I have my students 17 all day, every day. Is that 24/7? Oh,
Right,
okay.
right. Yeah, I don't know whether that was in regards to social media or just generally. I'll just answer it sort of with both in mind. I think, that the social media debate at the moment and what to do online, it's a kind of a big topic at the moment. And I think, as I kind of showed, there's a lot of nuance to it, and it's definitely not a problem, but it's also definitely not a problem for everyone. And there's kind of those individual factors I mentioned, and there's the way people use it. And I think the other thing to remember in terms of the advice for school students is kind of, thinking about what it might be replacing as well. So it's important that these kinds of devices and these behaviors don't replace good behaviors like, social connection in the real world or physical activity or these other things that are good sleep, So thinking about what it might be replacing is important. And then for mental health more broadly, as I kind of touched on as well, young people are much more aware and open about their mental health than they ever have been before, which is quite good. But yeah, it's about having safe conversations, and so there are some really good online resources from organizations like Origin, and ChatSafe is a specific resource that's been developed to help people have good, safe conversations about mental health and specifically self-harm. So I would encourage people to look for those types of resources. And the other organizations like Beyond Blue and these types of organizations help people understand how to have these types of safe discussions about mental health in those environments.
Another question. If I remember correctly, the data shown in the beginning can be interpreted as girls are more depressive, but boys are more suicidal. Is that true, or I missed it? Thanks for clarifying.
Yeah, so the figures that they're referring to, they did show, so when people have shown the sort of relationship between, say, social media and these mental health outcomes, you see the changes in the prevalence of depression and things rise steeper in females. That's true. And when it comes to self-harm presentations, for example, you see the rise in females, but you don't see the rise in males. But then when it gets down to suicide, you do see, that is when you see the gendered sort of the male effect come through. So that could be interpreted, yes, like females are more likely to engage in self-harm behaviors and end up in emergency departments, and then males that sort of suicide risk being higher, or seeing that relationship is more likely for that group. That's correct.
Do we know the reasons for those gender disparities?
I think self-harm and those types of behaviors in young people generally, we do know that females are more likely to engage in that type of behavior and you know, I don't know too much about the kinds of theory behind why that might be, and so yeah, I don't want to comment too much on that at the moment, but yeah, there is a field of research that looks at those gender differences for sure.
So there's a comment just thanking you for that, your answering the questions. We might wrap it up here unless there's any last minute questions. Great. So thank you for joining us for the talk today. Please do stick around for the next half hour. We will continue to knit neurons. Dr. Iorfino will be sticking around for a little bit if you know, for a chat or any questions. Yeah, thank you, and we'll see you next time.